everyone. I'm Dr. Chinya Rugoji, a 2007 graduate of American International School of Medicine with 10 years of clinical experience working as a certified nurse aide at various hospitals, long-term acute care facilities, nursing homes with patients in their private homes, from doing clinical rotations here in the United States, from from two graduate medical education programs, Henry Ford Internal Medicine Residency Program, Detroit, Michigan, Springfield Family Medicine Residency Program, Springfield, Illinois, from various observerships and externships, and from my various preventive health fairs where I've had the opportunity to have hands-on experience, and currently and a master's in business administration with an emphasis on public administration from Davenport University, Grand Rapids, Michigan, and research experience from UT Southwestern Psychiatry Department working with Dr. Carol North and Dana Downs, who are both awesome people. I'm currently involved in preventive health practice at my private practice, where I offer free health care to various community churches at various charity works, and also offer home visits. And I'm also part of the TAWOS campaign for the American Academy of Family Physicians smoking cessation program, and also applying for residency this year. And I want to welcome you all to Dr. Chiquito Mentoring Ustream Show, broadcasting live today at 1 p.m. Central Time. I want to apologize for the delay. There were some logistic issues, but I appreciate your understanding, and I promise that we are gonna be starting off on time, and we are gonna be having a very wonderful time on the show, and being able to learn what we actually to gain what we expect to achieve our expectations from watching this show. I want to thank everybody who has shown an interest, who has been part of this show. We've talked about lots of interesting topics in the past, and this week we've also talked about lots of interesting topics. On Monday we talked about croup, which is a viral infection, and I was opportune to talk to lots of people about it in the community of Dallas, and asked them the Powerball question, which is croup more common in boys than in girls? And I'm still getting the answers to that. And on Tuesday we talked about bronchiolitis, and that's also another viral infection too, which is also common during this time of the year. And we also got got a shot at the Powerball question, which is RSV washings of the nasopharynx, blood culture are all tests to be able to diagnose bronchiolitis. So the answers are still coming in. On Wednesday we talked about dysfunctional uterine bleeding, and I also got to ask questions about that in the community of Dallas, and the question was 5 to 10% of patients who present in the outpatient clinic are patients with dysfunctional uterine bleeding, and I'm still waiting for the answers for that. So the Powerball drawing will be done tomorrow, and today we're talking about septic arthritis. The show actually began on Tuesday, because on Monday we could not broadcast because we had some weather problems here in Dallas. So I want to thank you all. I want to welcome you all, and I hope you're all looking forward to a good weekend. This show is designed to be able to educate patients about common preventive health topics that we see in everyday life, that residents, that healthcare professionals, that physicians see even as they go on rounds, even as they see patients in their clinic. So these are the things that you see, and it's very important that you keep up to date about about them. So that's why this show was actually designed, to be able to carry along healthcare professionals and keep them up to date with current healthcare topics. And we always try to talk about something that we see every day in our clinics and also on rounds. And the physical exam and history taking is a skill that every healthcare professional has to learn. It's something that is the core of medicine. That's something that will aid you in being able to come up with a differential diagnosis, and also with an assessment and plan, and also to be able to get the patient to become to be healthy. So your treatment modality rests on a very, very thorough history and physical examination. So that's why I chose to dedicate one day during the week. During the week, we actually talk about lots of interesting topics. And coming up next week, we'll talk about cases too. How do you handle cases like real life, scenarios. Patient comes in and he has maybe like cholecystitis. What questions do you ask? What tests do you do? What physical exam do you do? So that's what we're gonna incorporate into the show coming up next week. But the physical examination, we'll be doing that once every week, and that's gonna be on Fridays. And with that, there are lots of things about the physical examination. Today we just talk about the overview, like just general questions that you should know, that should be able to aid you, give you the head start in being able to start the patient encounter, or to conduct the patient encounter. And after that, we'll talk about various pathophysiology in various parts of the body. So, and that will actually come up later on in the show. So with that, I want to start with the overview of the physical examination, and I want to invite anybody who has a question to feel free to ask the question. I have all of these. Yeah, I have all of these on my website, and I'm gonna be sharing it from my website, and I also have a video too that that is just the same content, but I'll be talking a little bit more about it today. So the overview of the physical examination. Well, first of all, the opening of the encounter. A patient comes in to see you. It could be a patient that that heard about you, that that's was sick, that's changed physicians, or maybe it could be an old a patient of yours, a patient that you've been seeing, a continuity clinic patient. So he comes to see you. What is the first thing that you do? Well, as you go into the patient's room, you should look at the patient's chart. Most of the time, the nurses actually keep the chart at the door, and you can just grab it and look at the patient's history. So it's very important to be able to have an idea of the patient's history, to have an idea of what other physicians have seen him for in the past. And also, most of the time, the nurses also have the vital signs and the patient's chief complaints. That will give you a clue, an idea of what differential diagnosis to be able to formulate. So that's the very initial step in being able to see that patient. So immediately you do that, you get prepared, come up with some differential diagnosis, have an idea of what the patient could be there for. And then armed with that, you knock on the door. That's very important, and then you go in and then you introduce yourself. So there are lots of ways you can introduce yourself. So you can say, "Hey, Mr. Jones, I'm Dr. Gorgie, or I'm Dr. A or Dr. B, and I'm glad to see you. How can I help you today?" Or you can say, "Hi, Mr. Jones, what brought you in to see us today?" Or you can say, "Mr. Jones, what made you come in today?" So those are some of the ways you can be able to break the ice and get the patient to know that, get him, and get the visits, kick-started, and also get the patient into a mood to be able to talk to you for excellent physician-patient interaction. So the next thing that we'll talk about is pain. That's a very important part of the physical examination. That's a symptom that most patients come in with, and sometimes the patient comes in with pain, and you're wondering, okay, what do I need to know about this? Well, it's very, very important that you ask some questions that will be able to get you to elicit the importance, the characteristics of the pain, so that way you can be able to characterize the pain. That way you can be able to incorporate it into your history, and also into your decision making pathway. So well, for pain, you want to know, well, first of all, you start by tell me about the pain. And then that way they can be able to talk to you about it. Some other questions that can be able to prompt the patient includes can you show me where exactly the pain is? They can point out where the pain is to you. They can point to their stomach or whatever part of the body that the pain is in, and that way they can be able to characterize the pain. And then you also want to know about the quality of the pain. You ask them, can you describe this pain for me? Is it sharp? Is it burning? Is it dull? Is it cramping? That way they can be able to tell you how the pain feels. And then you also ask them about the frequency. How often do you have this pain? Is it every week? Is it every day? That way you can also be able to characterize the pain. And then you also want to ask them about the onset. When did this pain start? And then you also want to ask them about the duration. How long have you had this pain, or when the pain starts, how long do you have it? And then also, you also want to ask about the radiation. Does the pain move anywhere? And you ask them where the pain moves to, because that's very important. Like in appendicitis, the pain starts from the right lower quadrant, and it moves up to the umbilicals, and that's due to distension of the peritoneal wall. So that's very important to be able to help you to know what the pathophysiology of the pain could be. And then also you also want to ask them about precipitating factors. What makes the pain start? About alleviating factors, what makes the pain better? About exacerbating factors, what makes the pain worse? And then also the timing. Does the pain occur with any timing? Does anything is there any time of the day that it occurs? And then also about any previous episodes, if they've had the pain before. It's very important to ask those questions. That way you can be able to get to know about the pain. Then in terms of nausea, that's the second symptom that we'll talk about. And some questions that you can be able to get the patient to describe his nausea is, do you feel nauseated? Do you feel sick to your stomach? That's a layman's language that they can be able to understand pretty easily. Then vomiting, some questions you can be able to ask to be able to get the patient to talk about his vomiting is, did you vomit? Did you throw up? Then what color was the vomit? Was there any blood in it? Can you describe the vomiters for me? So with that, they can be able to describe it for you. Then also, was there any bile in it? So the color is very important. The presence of blood, any bile in it, so all those are very important things that you have to be able to know about a patient who has vomiting. And then also for cough, that's also something that another symptom that patients present with, and you want to ask them some questions to get them to describe the cough. So you want to ask them, do you have a cough? Did you cough up any phlegm? That's this sputum. Can you describe the sputum for me in terms of the size? Is it like a teaspoon, like a tablespoon? That way they can be able to characterize the size of the sputum. And then also you also want to ask them about any presence of blood, because then you're thinking it could be a malignancy, it could also be like tuberculosis. And then also you also want to ask them about the presence of any associated factors, any fever with a cough. About timing of the cough. Does the cough happen at any time? What makes the cough better? What makes the cough worse? And then how often they cough. So with that you can be able to have an idea what the cough may be due to. Then in terms of headaches, you wanna most patients also present with headaches. That's something that you actually also wanna want to know what questions to be able to elicit a full history about headaches. So if a patient comes in with headache, what do you want to know? Well, you want to ask him, do you have any headaches? Can you describe the headache for me? Can you describe the quality of the headache? Is it like a pounding, like a pulsating? Is it like a sharp pain? And then also you want to know, ask them to characterize it on a scale of 1 to 10, how severe is the headache? And then also you want to also ask them about timing. Does the headache occur at any time? Then also you also want to know about the any prodrome. Do they feel like they have any sensation that the headache is gonna happen. Because then you're thinking it could be maybe like a cluster headache or migraines. Migraines, more commonly, and then also you also I also want to ask them about what makes the headache worse, what makes the headache better, any associated symptoms, thinking about fever, any tearing of the eyes, so those things are the things that you want to ask about the headache. Then also you also want to ask if they feel, if they have any vision changes, with the headache, if they have any fever or stiff neck, because then you're thinking it could be meningitis. And then also if they have any numbness or weakness, because it could be a stroke or a complicated headache or a cluster, a complicated migraine. And then also you just want to know if the headache wakes them up at night. Then for a fever, that's something that most patients actually present with. So you want to ask them, do you have a fever? When did the fever start? The onset of the fever. You want to ask them, if they measured it and what it was. With the temperature, and then also you just want to ask them about what makes it better, what makes it worse, and then also if they had have any chills, if they have any night sweats, if they wake up at night sweating. So that's how you actually get to elicit symptoms about a fever. Now, shortness of breath, that's another symptom that most patients come in with. We are 117 into the show. I don't see anyone who has posted any comment, but feel free to post any comments on my Facebook wall. We can be able to answer any questions you have. We're talking about the overview of the physical examination. How do you elicit a physical examination from a patient? So, yeah, so feel free to post on my on my wall, and then also shortness of breath. Do you get short of breath? That's something you want to know. And then also you also want to ask them how often do you get short of breath? And then also you want to know, do you get short of breath when you're walking or climbing stairs? How long they walk before they get short of breath? How many stairs do they climb before they get short of breath? That's very important for you to be able to characterize the extent of the symptom, shortness of breath. And also, just want to ask them about if they have shortness of breath at night, if they have to sleep on pillows at night. How many pillows do they have to sleep on at night? That's actually called autopnea, and that's it's described as 2 pillow, 3 pillow autopnea. That way you can be able to get an idea of what the cardiovascular pathology is. And then also you just want to ask them about if they have any leg swelling, if they have any wheezing, and then what makes the shortness of breath better or worse. And then with that, we are now down to the urinary symptoms. That's also something that most patients will present with. The urinary symptoms. So you want to get a good history of that. So you want to ask them, do you have any urinary symptoms? And then also ask them, can you describe these symptoms for me? Then what color is your urine? Any blood in your urine, any smell to your, any odor smell to your urine, any burning when you pee. Do you have to go to the restroom often, frequency, and then also do you feel like you haven't completely emptied your bladder after you pee? Do you have any urgency, like having to pee, like you can't control your bladder? And then any pain or burning during urination, any weakness in your stream, any dribbling of urine, because then you're thinking it could be prostate, prostate in etiology. And then also you also want to ask them about if they have to wake up at night to urinate, because then these questions will help you to from a differential. When it could be urinary tract infection, it could be renal pathology, could be prostate pathology. So with that, armed with the information that you get from asking these questions, you can now be able to, make a differential diagnosis. So now we're down to bowel symptoms, and then you want to ask them, how often do you have a bowel movement in a week? Because we talked about constipation earlier on, which is like less than 3 to 4 bowel movements in a week. So that's something that you want to ask, and then you also want to ask, do you have to strain during having a bowel movement? Have you seen any blood in the bowel movements? Have you what does your stool look like? Do you have any pain in your bowel, during the bowel movement? And then did you travel recently? And also, do you have any diarrhea? So, with those symptoms, diarrhea, how often they have a bowel movement during a week, any pain during defecation, any straining during defecation, any blood in their stool, if they traveled recently, and any mucus in their stool, will help you to be able to form a differential, for patients who have gastrointestinal pathophysiology. Now, for weight, that's where we are right now. We are 122 into the show, and we're talking about the various symptoms that patients present with, and what questions you can be able to ask, be able to elicit a good history and physical examination. So for weight, you want to ask about, have you noticed any changes in your weight? How much weight have you gained over what period of time? Was it intentional? Was there any change in your diet? With that, you can be able to know, how much weight they lost, and be able to have a differential diagnosis. I mean, it could be anorexia, it could be malignancy, it could be, those are your differentials, and with that, you can be able to form some differentials. Now, appetite, you want to ask them about their appetite. You want to know, how is your appetite, and then also, has there been any changes to your appetite? And by that, you mean, are you eating a whole lot? Are you eating less? Has your appetite increased or decreased? I mean, if your appetite has increased, then you're thinking it could be hypothyroidism. It could be bulimia nervosa. It could also be those two. It could be many other psychiatric pathophysiology. And then if the appetite has decreased, it could be malignancy. So with that, you can be able to elicit those symptoms and come up with a differential diagnosis. And also, next thing is sleep. That's something that patients will present with. Obstructive sleep apnea has actually been featured a whole lot, recently, in the American College of Physicians, magazines, so, and it's something that is also very, very important. So for sleep, you want to ask them about sleep. Have you been, how is your sleep? Do you, wake up at night? Do you have any problems going to sleep or staying asleep? Do you feel refreshed in the morning? Do you snore? Do you take any pills to be able to help you to sleep? Do you feel sleepy during the day? And then how many hours do you sleep at night? So with that, you can be able to get an idea of what their sleep patterns are, because then you're thinking, it could be obstructive sleep apnea. It could also be hyperthyroidism that can be causing the sleep problem. It could be medication induced. It could also be sleepwalk dysfunction. If their schedule doesn't allow them to sleep, that can make them to develop a sleep pathophysiology. So now we are down to dizziness. You want to ask them, do you feel dizzy? Can you describe that to me? Do you feel like like the room is spinning around you, or do you feel like you are about to fall out? yeah, did you feel lightheaded like you were about to fall out? So did you feel like the room is spinning around you, and did you feel lightheaded like you were about to fall out? So those are the two ways you can be able to help them to describe it, because I mean that way you can be able to know whether it's um, um, if it's of of neurology, etiology, or if it's of middle ear yeah, pathology. And then also you also want to know, ask them, did you black out, did you pass out, did you hear any ringing in your ears, do you feel nauseated, did you vomit, and then also ask them what causes this dizziness to happen, and what makes you feel better, what makes it feel worse. So with that, you can be able to know more about the symptom dizziness. So now we are at joint pain, and you want to ask them, have you had any painful joints in your body? Do you have any pain in any of your joints? Have you noticed any rash with your joint pain? That way you can be able to know more about the joint and start thinking of septic arthritis, rheumatoid arthritis, juvenile arthritis, Lyme's disease, systemic lupus erythematosus. With that you can be able to elicit those symptoms from the patient, and also be able to come up with a good differential diagnosis. Travel history. You want to ask them, have you traveled recently? That's actually important in the way of thinking about infectious disease, tuberculosis, Chagas disease. You're thinking gastroenteritis. So that's actually very, very important. Now, past medical history. You want to know, ask them, have you had any past medical illnesses in the past? Do you have any medical illnesses? Do you have any previous hospitalizations? Do you have any previous surgeries? Also, that's also past, yeah, part of past surgical history too. And then have you had any accidents or injuries? So that's eliciting the past medical history, the past hospitalization history, and also the past surgical history. And then you also want all of that recorded, because you have to go through the process of getting the notes from the physicians, and you also advise them to bring in their notes when they come to see you. Medications. You want to ask them, are you taking any medications? Can you tell me what medications you're taking? And also ask them, are you taking any over-the-counter herbal medications? Because all of those also count, towards towards the patient's medication history. The drug interaction that actually happens with the patients if they don't really keep an account of what medications they're taking. Now, allergies, we want to know about allergies. So you want to ask them, do you have any allergies? So with that, you can be able to know about the allergies. Are you allergic to pollen? Are you allergic to pollen? That way you can have an idea of what the allergies are. And then also you also want to know, ask them, do you have any allergies to any medications? So with that, you can be able to get more idea, a better idea of what the allergies are. Then next thing, we are into family history. You want to know, does anybody in your family have the same problem or anything similar? Does anybody in your family have any medical illnesses? Are there any diseases that are common in your family? Are your parents alive? Are they in good health? Are your brothers and sisters alive? Are they in good health? What did your mother or father die of? So most of the time you want to get ask them generally. Are there any diseases that run in your family? Is there anybody in your family that has any disease similar to what you're experiencing? And then after that, you now kind of narrow down to the nuclear family. You ask them about their mom, is their mother, their father alive? And then also, is their brother or sister alive, and what disease they have? Are they in good health? Because most hereditary diseases actually run in the nuclear family. They have a more a higher chance of being inheritable, if they are in the nuclear family. Then next thing is the social history. That's a very important part of the patient's health history. With preventive medicine, with everything that is being done, it's very, very important that you ask about about the social history, because you might think it's not important, but it's really important, because that will determine your treatment modality. So yeah, you want to ask them about their smoking history. You want to ask them, do you smoke? How long have you smoked? How many packs per day do you smoke? With that, you can be able to calculate the pack per day history. And then also ask them about, what do you smoke? Do you smoke cigars or cigarettes? And, have you ever tried to quit? With that, you can be able to know about their smoking history. Then the alcohol history, you want to ask them, do you drink alcohol? How much alcohol do you drink? How often do you drink the alcohol? Now, for illegal medication, and then also you just want to ask them about the cage questionnaire, especially if you feel that they might be drinking too much. So the patient comes to you, and they say, "Oh, I drink every day." Then that could probably get you concerned, and then you want to administer something called a cage questionnaire that will help you to know if they have an alcohol problem. So you want to know. Ask them, have you ever felt the need to cut down on your drinking? It's called the cage. The cage questionnaire. So, have you ever felt the need to cut down on your drinking? Do you feel annoyed by criticism of your drinking? Do you feel guilty about your drinking? Do you have to have an eye opener in the morning before you head out? So with that, you can be able to administer the cage questionnaire and be able to know if they have an alcohol problem. And then with that, the next thing that you want to ask about is illegal medications. So you want to ask that by asking them, do you use any illegal medications? What illegal medications do you use? How often do you use them? What effect do they have on you? Have you ever tried to quit? And then, do you smoke or inject them? All these questions are sensitive questions, because these are the patient's personal life, but they actually affect the patient's overall health. So it's very, very important that you ask them these questions in a very in a very, very direct way, but also a way that will get them to open up. And what I normally do is to actually before I start the social history, I tell them, hey, Mr. Jones, I'm going to ask you some questions about your social history. This might actually be a bit embarrassing, but it's or a bit or might seem a bit unusual to you, but it's gonna help me to be able to determine what exactly your medical problem is. So with that, they can be able to feel more comfortable and be able to open up to you. And then the next thing is occupation. So you wanna ask them about what job do they do. So you ask them, what work do you do? Any stressful situations around your job? How long have you worked at your job? And then with that also ask them about the educational history. Are you what's your educational history? What's your highest level of education? And then you can be able to know. And then also, are you exposed to any environmental hazards on your job? Because that actually makes a very big difference on what the pathophysiology of their disease is. Now, next thing that you want to ask about is their living situation. So you want to know who do you live with? Are you happy? Are you comfortable where you're living? Are you happy? Where you're living. That's especially if you suspect elder abuse or domestic abuse or sexual violence. So that's very, very important. And then also tell me about your life at home. That's a general question that you can ask to be able to get them to just open up to you. And then marital status. You want to ask them about their marital status. You want to ask them, are you married? Are you separated? Are you divorced? Are you do you have any children? That's also very, very important. Now, the next one is the sexual history. That's also part of the social history, and and that consists of a whole bunch of questions that is designed to be able to get them to talk to you about your sexual history. So you would probably start out by saying, I'm going to ask you some questions about your sexual history, which might be a bit unusual, but just feel comfortable. Anything that you tell me is going to be confidential. So you want to ask them, are you sexually active? And then also ask them, are you sexually active with men, women, or both? That's very important. Also, are you then also, how many sexual partners have you had within the past 1 year? Then also ask them, have you ever been treated for any sexually transmitted diseases, or have you had any STDs in the past? and also ask them, do you use contraceptives? Then also ask them, are you happy with your sexual life? Do you have any problems with erections? And then have you ever been tested for HIV? So with that, you can be able to get an idea of what their sexual history is, and that's also very important. So the next thing is the gynecologic or obstetric history, and so and with these questions, you actually get to elicit symptoms about their gynecologic or obstetric history. So you want to ask them questions about their gynecologic history, and then also their obstetric history if they've had children in the past. So you want to ask them, when was the first time you had a period? That's menarche. How often are your periods? Are they regular, every 28 days? Any spotting in between? How many pads or tampons do you use per day? And then also ask them any pain during your periods, dysmenorrhea, and then also ask them how long do your periods last, and any changes in their periods. And then the next thing is the obstetric history. So you want to ask them, have you ever been pregnant? And then how many how many times, and then also how many children do you have? Then also ask them to tell you about your pregnancy. Was the pregnancy complicated? And then did they attend all the prenatal visits? Did they take any any medications during their pregnancy? Also ask them, was it a normal spontaneous vaginal delivery, or was it a cesarean section? And then also ask them if they've ever had a miscarriage or an abortion, and in what trimester. And then and then with that, you can be able to characterize the obstetric history. Some other things that I did not talk about during the gynecologic history was, have you ever had a pap smear before? That's very important. Then do you have any problems controlling your bladder? Do you have any vaginal discharge? What color is the discharge? What amount is it? Any abnormal bleeding? We talked about that before. Any smell to to the discharge? Because then you're thinking it could be cervicitis, it could be gonorrhea, it could be chlamydia. And then do you have any pain during intercourse? That dyspareunia, because you're thinking it could be menopause, it could also be cancer. So with that, you can be able to get an idea of what your gynecologic and obstetric history is. So the next one is pediatric history. That's normally in little kids, and you ask the mom about this pediatric history, because it's very important. Kids are actually pretty cute, but they actually you have to ask the right kind of questions, be able to know how to tailor the management, to their age and also to their diseases. So you want to know about pregnancy, because the kid's health starts from the mom. So you want to ask about, was your pregnancy full term? That's 9 months. Was it were there any complications during your pregnancy? Did you take any medications during your pregnancy? Then was it a normal vaginal delivery, or was it by C-section? And then did the child go home with you immediately after delivery? And did you attend all your routine prenatal visits? Were any ultrasounds done during your pregnancy? Then does your child have any medical problems? No, did your child have any medical problems after birth? And then when did your child have his first bowel movement? So with that, you can be able to know about the pediatric history. Then growth and development, that's for mostly on pediatric and adolescents. So that's lots of questions that are meant to make sure that the child is actually up to date on his growth and development. So you want to ask, when did your child first smile? When did your child first start crawling? When did your child first start running? When did your child first start using full sentences? And when did your child start first going to the restroom himself? And when did your child first start talking? or start using short sentences, and when your child learn to tie his shoes, dress himself, and also start putting things in his mouth. So with that, you can be able to elicit what stage of development that the child is in, and make sure that everything is fine. And then also, you also want to do the growth chart, find out where the child is on the growth chart, and be able to know what percentile he is in, so you can be able to make sure that he's up to date, his diet, his diet is fine. And then also, yes, I also want to ask about their immunization. Is the child up to date on their immunization? Then next thing is feeding. So you want to ask about the child's appetite. How is the child's appetite? Is he eating okay? Has there been any changes in his appetite? Is your child's formula fortified with iron? Are you giving your child pediatric multivitamins? Did you breastfeed your child? That's very, very important. And when did your child start eating solid food? So with that, you can be able to elicit what the child's health status is in terms of his feeding, and also multivitamins, allergies, appetite, and also immunizations too. And then also, you just want to know, has your child had any serious illnesses? When was the last day of your child's routine checkup? And then, is your child taking any medications? Has your child ever been hospitalized? So with that, you can be able to know about your child's history. Psychiatric history, that's actually aimed at knowing, having the patient talk to you about the symptoms they're experiencing, the psychiatric symptoms they're experiencing. And sick caps, that actually helps you. That's a code that we actually used in medical school. You want to ask about, do you have any sadness? Do you have any loss of energy? Do you have any loss of interest in your regular activities? Do you have any unusual feelings of guilt? Do you have any loss of concentration? Do you have any loss of appetite? Do you hear voices or see things that people don't see? Do you feel that people are out to harm you? Do you have any unusual beliefs? Do you have any memory problems? Has your appetite changed recently? Has your weight changed recently? Then tell me how you spend your time and day. Do you have any problems falling asleep, staying asleep, or waking up? What interests or hobbies do you have, and do you enjoy them? Do you have any difficulty concentrating? Do you have any hope for the future? Have you thought about killing yourself? Suicide, that's something that you have to decide, especially if the patient, talks, actually, seems like they might be suicidal. If you get that feeling, it's very, very important for you to be able to ask that before the patient leaves the room. And then also ask them, would you mind telling me about it? And then, have you lost any interest in your social activities and relationship? Do you feel hopeless? Do you feel guilty about anything? Who do you live with? How do they react to your behavior? Do you have any problems in your job? How is your performance on your job? Have you had any recent emotional or financial problems? Have you had any recent traumatic events in your family? Does anyone support you? And then how is your energy level like? So with that, you can be able to get an idea of what the psychiatric history is. Then for dementia patients, it's very important to be able to ask about their daily activities, because that's a sign of dementia, not being able to carry out their daily activities. It gets progressively worse over time. And so, you want to ask by asking, about their daily activities. Do you have any problems with eating, with cooking, with bathing, with paying your bills, with shopping, with making telephone calls, I'm getting dressed, any accidents with your bowel or urine, or urination. Then also, do you need any help feeding yourself? And then also, do you need any help taking medications, doing laundry? So just basically asking them about about the daily activities, and being able to determine what their functional level is. And that's actually very, very important in determining in the DSMV classification, and I'm being able to determine what their global assessment of living is. Then also for abuse, that's something that is actually quite passionate to me. I do lots of counseling about domestic abuse, sexual abuse, and domestic violence. So so you want to ask, are you safe at home? Are you afraid of anybody in your environment? Have you been abused before? Are you scared of abuse? Then can you tell me about any bruises on on their arm? If the patient comes in with a bruise with some abnormal discolorations, you want to know what caused the bruise, because then you're thinking about abuse. So now we want to go to the physical examination. So with that, you have an idea. You've talked to the patient. You now know, okay, maybe this patient has chest pain, and he's described with chest pain, with nausea, with vomiting, chest pain that goes to the left. So you're thinking, it could be anything. It could be MI, pericarditis. It could be pleuritis. It could be costochondritis. So that now you have a differential that will help you to know what physical examination that you need to do, which is very, very important. Most times in exams, you want to do a focused physical examination, especially if it's a patient that just came in for a simple complaint. And also in your clinics too, it's also important to do a focused physical examination, because that will help with billing. Most times, billing for a focused physical examination is like 9912, 9913. For a full examination is 9914 and 5. So it's very, very important to be able to make that clinical decision of what physical examination that you want to do. If it's a patient that just came in for a physical examination, maybe like a sports physical, or like a health assessment, then a full physical is actually warranted. A patient who hasn't seen a physician in like a month, or like in a couple of years, for like a year, or in a couple of years, then you might want to actually do a full physical. But if they have maybe abdominal pain and nausea, then it's very, very important to just do a focused physical examination, because that will save time. That will get you to be able to address the patient's symptoms, and also be able to get you to come up with an assessment and plan faster, and and also with billing too, because you don't want to get the insurance companies not working with you, especially if that's something that we'll talk about later on, coding and billing. That's a very, very important part of practice, and also part of the whole medical career. And then so for the physical examination, first of all, I normally start with the general survey. After talking to the patient, you have an idea of what the patient is like, what his symptoms or what his complaints are, an idea about the patient's state of mind. So as you're talking to the patient, you're doing a general survey essentially. But then you can actually but it's very important to be able to get that part of the history taking process done, because it's very, very important to be able to have an idea of the patient's appearance, and also functional status too, and you can get that by doing the general survey. So just observe the patient's general state of health. Are they healthy? Are they robust? Are they frail? Are they cachectic? Also observe the patient's appearance. Are they in good appearance? Are they well dressed, or are they poorly groomed? Also assess for also assess the facial expression too. Is their facial expression normal? Or do they have flat affect? And then also observe their dressing, their grooming, their sexual development too. That's also very, very important. And then also their build and their height, that you can be able to glean just looking at the patient. And also you also want to also observe the posture, the motor activity, and the gait, and any and then also the personal hygiene and any odors of the breath or body. So that's very, very, very important. Knowing and being able to observe their gait, their motor activity, their personal hygiene and any odors of the breath or body. And also their dress and their grooming. That will help you to be able to make a differential diagnosis. I mean, if a patient has ataxic gait or or a broad-based gait, then you can be able to start thinking Parkinson's disease, or a neural malignancy. And then for others of breath and body, I mean, that can make you start thinking maybe like depression or maybe like diabetic ketoacidosis. So all of that will help you to be able to have an idea of what the patient actually came in with. And then also the patient's facial expressions, we talked about that, and manner of speaking, affects and also reactions to persons and place in his time. His environment. Does he have an appropriate affect, and does he have a flat affect? What manner of speaking, does he, what's manner of speaking? Is his speech slow? Is his speech slurred? Is his speech fast? Because then you're thinking maybe it could be medication induced. He could be on some illegal medications, or he could actually be hypothyroid, or he could actually be depressed. So all of that will get you to start thinking of a differential diagnosis. And then also his responses, if he has slowed response, that's hypothyroidism, that's depression. Then also the patient's skin color, and look for any obvious lesions, because as you're doing the general survey, you're looking at the patient, noting the skin color and obvious lesions. That will, but some things will jump out at you immediately, and with that you can be able to have an idea of what the patient looks like, and you can be able to note that in the note section where it says general survey. And then also note if the patient is in any distress, if the patient is calm. That's very, very important. So the next thing is the head, eyes, nose, and throat exam. So you wanna tell them what you're doing. So some things that you can say as you're doing it. It's very, very important to communicate to the patient as you're doing the physical examination. You wanna talk to them, tell them what you're about to do. That way you don't surprise them, and that way you get a better result. So you tell them you wanna examine the head. You wanna check the hair, check for any lice, check the state of the hair, and then also check and palpate the head for any tenderness, and then also check for any lesions. And then also you just want to palpate the sinuses. So you tell the patient, I'm gonna examine your sinuses. I need to press on your forehead and your cheeks. Tell me if you feel any pain anywhere. So that's actually feeling for any sinus tenderness. And with that, we can be able to diagnose sinusitis, sinusitis, or any sinus pathology. And then also you also want to tell them I need to examine your eyes now. That's if you want to examine their eyes. So with that they can be able to know. Then tell them I'm going to shine this light in your eyes. Please can you look at the clock on the wall? So most times you want to do an optic examination, so you are gonna shine a flashlight into their eyes. So it's very important to tell them that. And then also I need to examine your ears now. If you're doing an ear examination, then can you please open your mouth? I need to check the inside of your mouth and your throat if you're doing a mouth examination, an oral examination. Then what to perform during the head, eye, ear, nose, and throat examination. For the head, you want to inspect the head for any signs of trauma and scars. That's very important. You want to palpate for any tenderness, abnormalities. For the eyes, you want to inspect the sclera and conjunctiva for the colon and any irritation. You want to check the pupils for symmetry and reactivity to light, and you do that using your flashlight. You flash the light, approach the patient, flash the light, and then you check the size of the pupils if there's any dilation or constriction. And then also you want to check the extraocular movements of the eyes. And how do you do that? Well, you put your hand up to the patient's face, and then you go from side to side, up, down, just like that. And then just kind of watch the patient's eyes and see how the patient's eyes move. If the patient has any brain tumor, then they could have ataxia. They could have problems with that particular test. So that's very important to note. And then also you also want to do the visual acuity with the Snellen eye chart. So you have the Snellen chart. It's only very convenient to put it in your pocket, and it comes in a handheld version. And most offices also have it too. So stand a few feet away from the patient and ask them to read it off for you. Have them close their eyes and read it off for you. And then you check both eyes. Check both eyes. Consecutively, check one eye at a time. And also perform a fundoscopic exam. The fundoscopic exam is actually a test to be able to check the fundi of the eyes. See what it looks like. And checking for end of end damages of hypertension or renal disease. So you wanna use the rule right, left. So that's your right hand against the patient's right eye, and then also and then also in your own right eye, right hand, patient's right eye. So left hand, left eye, patient's left eye, and that with that you can be able to have a clear view without discomforting the patient. So it's right, and then left, and then with that that concludes the eye examination. And then with the ear examination, you want to just conduct an external inspection of the ear. Just look for any masses, any lesions or any discolorations. And then also with that you want to palpate the ears to check for any tenderness. Check if they have any pain in the external ear, because that could be due to arthritis externa, especially if they are swimmers. So that's something that can be able to help to elicit that symptom. And then also do the same for the mastoid too. So palpate the mastoid bone, which is like here. So just push against it. If they have a mastoiditis, that will actually come out positive. They'll express some pain, and that's a sign for mastoiditis. And also examine the ear canal, and you do that using the equipment, the otoscope. So it's always very important to use one ear speculum for one patient. After using it, put it in the trash, and then also find the appropriate one for them. Use the one, it comes in different sizes. So make sure that you have the right size for them to avoid inflicting any pain. And then you just plug it in. It comes with a light. You put it in their ear, and then you look through there, and then look into their middle ear. And you're looking for at their eardrum, to see if there are any redness, if there's any fluid, if there's any other middle ear pathology. And with that you're thinking maybe it could be arthritis media, or it could be foreign body. In kids, if they have a foreign body, it could be that. It could be tympanosclerosis. With that you can be able to look at the middle ear bones, and so. And then also check for effusions too. That's very, very important. We talked about arthritis media sometime during the show. We talked about the different types of serious arthritis media. So that will help you to be able to determine, help you in the clinical decision pathway. And then also you also want to conduct the Ryan and the Weber test. The Ryan test, these are both specialized tests. We're able to check for any auditory pathology, with ear and bone conduction. So with the Ryan test, you use a auditory fork. Normally it's 512 megahertz for the Ryan test. And for the Weber test, it's normally 256 Weber test, 256 hertz. So for the Ryan test, you actually get the tuning fork, vibrating by hitting it on your head, and then you put it against the mastoid process, and then also against the ear. So normally the ear conduction should be better than the bone conduction. So you put it against the mastoid process, and then ask, and then before it stops vibrating, you put it against the ear, and then ask them if they hear it. So if they hear it, then it means that there's no problem. But if they don't hear it, it means that they have that their bone conduction is actually better than the ear conduction, which is a sign of conductive hearing loss. Now, if but if they don't hear it, then that's conductive loss. Conductive hearing loss. So that way you can be able to know. And then with the Weber test, that's actually the test to be able to check for hearing loss too. And with that, you use the 256 hands, and then you get it vibrating by hitting it against your hand, and then putting it on the patient's forehead, and also against the patient's ear, and then see if they actually hear it. No, I'm sorry. You put it on the patient's ear, and then see if they hear it equally on both ears. And if they don't, then that's a sign of hearing loss pathology. And then I'll talk about this specialized test later on in the show in the future. Then for the nose, you want to inspect the nose. You want to palpate the nose and the sinuses, and then also inspect the nasal turbinates and the nasal septum with a light source. Then with the mouth or throat, you want to inspect with a light, and you can also do tooth tapping. Then for the cardiovascular exam, you want to tell the patient what you're about to do. You tell them, I need to listen to your heart and to your heart. Can you hold your breath, please? Can you sit, please? Can you turn to your left side? I need to examine your legs to check for fluid retention. Is that okay with you? I need to check the pulse in your arms and legs now. So with that, that will walk them through the cardiovascular examination. And then also, what to perform during the cardiovascular exam. You want to leave the patient's gown. You actually do not want to listen over the gown. It's very, very important to respect the patient's privacy. So you want to listen over to pull their gown down, and then listen under their gown after telling them. And then also you want to listen for carotid bruit. So put the stethoscope right here, and then also right here too, to listen for any carotid bruit. And then also look for JVD too. And you do that by elevating the patient's head and checking for JVD. And most times, if they have any cardiovascular pathology, it's very, very obvious, and you have to also measure the size of the jugular venous pulse. Normally 3 to 4 cm. If it's more than that, then that's actually a sign of pathology. And then also you also want to also palpate the heart for the point of maximal impulse, and that's normally on the left side. On the left side you palpate, and then also you also want to check for retrosternal heaves and trails, and that's actually for advanced cardiac pathology. And also you just want to listen to at least 2 of the 4 mitral areas. The 4 cardiac areas. The 4 cardiac areas are the aortic area, the pulmonic area, which is the second intercostal space on the left and on the right, respectively, aortic and pulmonic, and then also the mitral, the tricuspid, which is in the left lower heart border, and then the mitral, which is in the 4th to 5th intercostal space, and the apex of the heart. So, but it's very important to listen to at least 2 of the 4 cardiac areas, and that will give you an idea of what the patient's cardiac physiology is. And then also listen to the base of the heart with the patient leaning forward that's also a very, very good a good maneuver. And then also check for pedal edema and check the peripheral pulses. So the radial pulses, the popliteal pulses, the dorsal pedis. Check all of the pulses, and that's the cardiovascular examination. So now we are at the pulmonary examination. So what do you want to say to the patient before you examine him? Well, you want to tell the patient, you need to listen to your lungs now. Can you take a deep breath for me, please? Can you say 99 for me? I'm going to tap on your back to check your lungs. Is that okay with you? So with that, you can be able to do a pulmonary examination. And then how do you do the pulmonary examination? Well, first of all, you examine the patient. You want to look at the patient's front and back. Check for the patient's breathing to make sure that they have even inspiration or even expansion of the lung fields. If the patient has like a flared chest, or maybe then you see some uneven expansion of the lung chest. So that's actually the first thing that you do. Then after that, you wanna listen to auscultate, and you do that by auscultating in at least 4 areas on the front and back. That's because the lung has upper, lower, upper and lower, and then also, and then you have the lingular on the right hand side. So you have to listen in all parts of the lung, and then also you also wanna palpate for any tenderness, for any tactile firmitude. So palpating, you just put your hand over their chest, palpate, ask them if they feel any pain, and then also you also want to check for tactile firmitude. So you put your hand and you ask them to say 99 and make sure that the lungs are vibrating. That way you can be able to detect any consolidation in their lungs. And also you also want to put your hands and also make sure that the lung fields are moving. That's to check for even expiration. And also for percussion, you want to percuss. So you put your hand on their chest, and then you just tap in all the lung fields to make sure that the lung fields are actually functioning. And then after that, you wanna auscultate, so auscultate in all the lung areas, and you also want to check for egophony, and that's putting your hand on the chest wall, and then asking them to say A, and see if it become if it sounds like an E, or if it feels like an E. That way you're thinking maybe it could be consolidation. So with that, you're done with the pulmonary exam, and now we are actually at the abdominal exam. So what do you say to the patient as you perform the abdominal exam? Well, you want to tell them, I need to examine your belly and your stomach now. I'm going to listen to your belly now. I'm going to press on your belly. Tell me if you feel any pain or discomfort. I need to tap on your belly. Do you feel any pain when I press in, or when I let go? Which hurts more? So that's actually very, very important. You have to describe the steps to them. Tell them, I'm gonna listen to your belly, I'm gonna press against your belly, I'm gonna tap against your belly, I'm gonna push against the belly, and then ask you to tell me if it hurts more when I push or when I let go. That's a test for rebound tenderness, and with that, they can be able to work with you to be able to get an efficient test done. And then also, what to perform during the abdominal exam? Well, you want to inspect, so you actually inspect, look for any scars from any previous surgeries, any obvious pulsation, if they have any aortic pathology, and then also and then also auscultate. It's very, very important to auscultate before you actually palpate, because you're actually listening for bowel sounds, which are sounds made by the bowel, and if you palpate, then that will raise up some bowel sounds which will disguise the true nature of the patient's bowel sounds. So the auscultation, you listen and see, what the vowel sounds sound like. Are they high pitched? Are they normal? Are they tinkling? With that you can be able to start thinking. I mean, it could be an obstruction, or it could be just normal vowel sounds, or it could be diarrhea. And then also you just want to percuss. So put your hand against the patient's stomach and then you tap on all the fields, all the abdominal fields. And then also you also want to palpate. And how do you do that? Well, you start from the area that is further away from the pain. So I mean, if the patient comes in and they and they have pain in the right lower quadrant, then you want to start from maybe the left upper quadrant and then make your way down to the right lower quadrant. That way you can be able to avoid any unnecessary discomfort to the patients. And then also you also want to avoid re-eliciting the pain. So you push on the right lower quadrant and the patient says, ouch, don't push there anymore. And then also check for rebound tenderness. How do you do that? Well, you actually put your hand on the patient's stomach and then you push on and then ask them, you let go and ask them if it hurts when you push in or when you let go, because then that's actually a sign of rebound tenderness, meaning that which is actually caused by irritation of the peritoneum. And then also you also want to check for severe tenderness. That's for any renal pathology, and you do that by putting your hand against the patient's back and hitting against the patient's back, and that will tell you if there's any renal pathology. Check for the obturator sign and the psoas sign. These are all signs for appendicitis and also for any obturator or psoas abscess. So the obturator sign and psoas sign, the obturator sign is actually internal rotational flexion of the hip joint. And then and with that you can be able to elicit any symptoms or any signs of appendicitis. And then the psoas sign is you ask them to push against your hand. You put your hand against their knee and then ask them to push up, and that way you can, and then if you elicit any pain, that's actually a positive sign. And then also the Murphy sign, we talked about that earlier on when we talked about cholecystitis. You put your hand on their stomach, and then you ask them to take a deep breath, and if they feel any pain during inspiration, then that means that it's a positive sign, and that's actually because of the diaphragm touching the gallbladder. That's the sign of cholecystitis. And then also you just want to check the liver span too, and you just tap. The liver is a hollow organ filled with blood, so as you tap, you cannot miss that sound, and that will help you to be able to check the liver span. And then so now we are done at the neurologic exam, which is a very, very important component of most exams, especially if it's a complete physical examination. If it's a patient that you suspect might have some neurologic pathophysiology, it's very, very important for you to be able to know how to do that. So some things that you want to say is, I want to ask you some questions to test your orientation. I want to check your memory and concentration by asking you some questions. So you want to ask them, can you tell me your name and age? Can you tell me what day it is? Can you tell me where you are? So that way, you make sure that they actually, alert and oriented times 3. They actually know where exactly they are. And then also, you don't want to, tell them 3 things. I mean, normally, you want to check their memory. So you ask them short-term memory. Tell them, okay, I'm going to tell you 3 things: a pen, a computer, an umbrella, and then I'm going to ask you for this later on. They will tell you. They will say okay. And after that, you ask them, show them some objects and say, do you know what this is? Do you know what this is? That actually tests for orientation. And then also you want to ask them to repeat those things that you told them. So that checks some short-term memory. And also ask them if they remember what they had for lunch yesterday. That checks some recent memory. And then ask them when they got married. That checks distant memory. And then ask them if they are left-handed or right-handed. So that will now lead into the next test, which is actually giving them a piece of paper and asking them to fold it in half, or ask them to form a shape. That's actually being able to know if they're able to follow commands, and then also ask them to write their name on the paper. That's also being able to know if they can follow commands, and then also ask them to count backwards, backwards starting from the number 100, or take 7 away from 100 and let them know what number they come up with. So that actually tests concentration. So you ask them to count down in sevens from 100, or you ask them to take the number away, take 7 from 100, and then just keep on going till you ask them to stop. So that will help test that they're actually concentrating and they can be able to solve that task. And also ask them what they would do if they saw a fire coming out from a paper basket. So that tests judgment. Just some questions that you can ask about judgment. And then before the rest of the neurologic exam, for the reflexes, tell them, I'm going to check your reflexes right now. This might hurt a little bit, but I'm actually doing it to be able to make sure that your reflexes are okay, which is part of your neurologic exam. And also, I'm going to test the strength of your muscles. That's actually for checking the motor function of the patient's motor function. And then also, I'm going to ask you to tell me if you can feel this. Ask them to close their eyes and then put a cotton pad and a cotton board, and then also a sharp object too, to make sure that the sensory part of their neurologic examination is actually normal. And then also ask them to tell you what direction you're moving their toe up, with your eyes closed. And then also ask them to walk across the room. Can you walk across the room for me? So with that, that actually gives them an idea of what you're going to be doing during the neurologic exam. So the neurologic exam normally starts with the mental studies exam, which we just did. So that was actually a comprehensive mental studies exam. The mini mental studies exam is just asking them their name, where they are, what date it is. So but that's the comprehensive mental studies exam. And you now go down to doing the cranial nerves. So you want to do start with the cranial nerve 2, and that's checking for vision. So you want to check for vision using the Snellen chart, and with that you can be able to know what their vision is. And then you don't want to check for cranial nerve 3, 4, and 6. That's checking for extraocular movements. We talked about that earlier. Just put your hand, ask them to move from side to side, and then you can be able to know what the extraocular movements are. And that's for cranial nerve 3, 4, and 6. And then you want to check for facial sensation. So you use a cotton ball and you press on their face, and then you ask them if they can feel it, with their eyes closed, and ask them to point where it is. And also check for feeling of sharp, get a sharp object like a toothpick, and then put it on their face or on their body, and ask them to be able to point where exactly it is. The sensory and the sensory, the pain and the sharp and the dull sensations go through different pathways, so it's very, very important to be able to do that. And then also you also want to check for the muscles of mastication. So you actually push, and put your hand on their cheek, and then you also ask them to clench down and make sure that the muscles of mastication work, because these are all supplied by the facial nerve. And also so that's cranial nerve 5. We are cranial nerve 5 right now, facial sensation and muscles of mastication. Now cranial nerve 7, that's actually the 5 is the trigeminal, 7 is the facial. So you ask them to smile, ask them to lift their eyebrows, ask them to close their eyes and don't let you open them. So with that, that will actually that's actually checking for for any abnormalities. And then also cranial nerve 9 and 10 is that's the glossopharyngeal and the vagus. So you actually ask them to swallow, make sure that there is symmetric palate reflex, and then also the gag reflex too. You ask them to you put an object in their mouth and see if you can be able to elicit a gag reflex. In patients who have a stroke, that's actually absent, so that's very important. Then for cranial nerve 11, you ask them to shrug their shoulders against your hand. So just put your hand like this, and then ask them to shrug their shoulders. So that's checking for the accessory nerve, because that's what supplies the muscles over here, the sternocleidomastoid muscles, and that way you can be able to make sure that nerve actually works. Then for cranial nerve 12, you ask them to stick. 11. You ask them to stick out their tongue. That's the hypoglossal. So with that, you can be able to ensure that actually works. And then for the motor system, you wanna check for passive motion. So that's asking them to push against your hand, and you do that for the upper and lower extremities. You do that for both the upper, the biceps, and then also the lower part of the arm, and also do that for the thighs, and also for the lower legs too. Ask them to push against your hand. So that's testing for passive motion, because they're not doing anything. And then also for active motion, you also want to ask them to kick out, to be able to move their hand up and down, to flex, to extend, and that way you're checking for active motion. And also you also want to ask them to spread their fingers apart, and also to close their fists. And then also knee extension, knee flexion, that's kicking out and pulling in, just similar to the upper body. And then also for the ankles, ask them to push on the gas. Then for the reflexes, you want to check for the biceps, the triceps, the brachioradialis, the patella, Achilles, Babinski reflexes. You do that with the hammer, and so hopefully you can be able to demonstrate some of that on the show. I'm actually working on a clinical skills video with a live SP. I'm also looking for someone who can be able to volunteer, or to be also work with me to be a live SP for me. So contact me if you're interested. I'm willing to discuss that with you. And then also for the sensory system, you want to use the cutting board and then a sharp object, to check for their sense of sensation. And then also you also want to check for vibration. So you use the tuning fork, and then you put it against your hand and ask them if they feel it. And then also for position, you ask them to close their eyes, and then put your and ask them to tell you if they can feel their toe going up and up and down, and then that way you can be able to know if they have a sense of position. And then for cerebellum, you want to do the finger to nose test. So that's asking them to put their finger on their nose, and then also to touch your hand, and you move from side to side very rapidly, and see if they can be able to follow that. That's actually testing for the cerebellum. You can also do a heel to shin. Ask them to lie down, put their heels against their shin, and then just kind of move it up and down, and see how fast they can be able to do that. And then also ask them to do rapid alternating movements, maybe against your hand or on the table, and then that way you can be able to know what shape the cerebellum is, because the cerebellum is actually what is responsible for maintaining balance, and also balance. And also the Rombeck sign too. You ask them to stand up, and then put their hand out, close their eyes. Some people do it by just asking them to close their eyes, and see if they fall from side to side, or if they actually pass out, or so. And with that, you have to be very, very vigilant, because it's very, very important to be vigilant in case they actually have a positive Rombeck sign. So if they fall from side to side, or feel like they're gonna fall out, then that's a positive Rombeck sign. And then you wanna check for neck stiffness. the Koenigs and the Brzezinski sign. Those are all tests to check for meningeal signs. Ask them to lie down, then push their head up and see if they feel any pain in their back. That's the Brzezinski. Then the Koenigs is you put your hand under their leg, push their leg up and then see if they feel any signs in their spine. That's the Koenigs, and that's actually signs of meningitis. Now for the joint exam, you as a patient, most patients come in with joint pain or joint stiffness or inability to walk or fever or crepitus. So you want to ask them, do you have any pain in your joint? Tell me about the pain in your joint. I'm going to examine your knee or ankle now. So what to perform with the joint exam? Well, you want to inspect, checking for erythema, any inflammation, any redness around the joint, any trauma, any scars from any previous surgeries or from any trauma. And then also want to palpate. So you just push against the joint from side to side very gently. And you're palpating to see if there's any pain, if you are able to elicit any pain. And also checking for something called crepitus. It's a very interesting clinical sign. As you push, you can feel something like crack, crack. So that's, like signs of arthritis. And also check for effusion. Effusion is very, very easy to find. And once you push against the patient's joint, you feel like fluid, and that's actually a sign of arthritis too. Most of the time, rheumatoid arthritis. And then also check the joint range of motion. So you ask them to stand up and move the joint from. Ask them to lie down or sit down and move the joint from side to side. Flex the joint, extend the joint, and then see how the range of motion is. With that, that's the end of the overview of the physical examination. We talked about the opening of the opening encounter. We talked about nausea, about pain, about vomiting, about cough, about headache, about fever. We talked about shortness of breath. We talked about bowel symptoms, urinary symptoms, weight, appetite, diet, sleep, dizziness, joint pain, travel history, past medical history, past hospitalization history, past surgical history, medications, allergies, family history, social history, smoking history, alcohol history, illegal medications, occupation, living situation, marital status, alcohol, sexual history, gynecologic and obstetric history, pediatric history, growth and development, feeding, psychiatric history, daily activities for dementia patients, abuse, and then we talked about the physical examination from general survey all the way through neurologic exam to joints. So with that, we have an idea of what we should be able to do as we see our patients. But all these are specialized. And there are some things that you have to know about the physical examination, especially if you're tailoring it to a particular case. A patient with COPD, there's some things that you actually have to do, that are quite specific to COPD, and we'll talk about that as we go along. So with that, it's 2:28. I don't see anybody asking any questions. But yeah, but I hope that if you're watching this stream, sure that you're actually learning a whole lot about the overview of the physical examination, and also about how important it is for every healthcare professional, for everyone to know what to expect when you go to a physician. So with that, we'll go to the next topic, which is septic arthritis. That's our preventive health topic of the day. And these topics are actually designed to be able to help us to be able to understand these health topics that we see every day. It's a very, very very common topic, and I was privileged to talk to various people in the community. Yeah, so I'm putting up septic arthritis right here. Yeah, so I have a case study on my website that is actually designed to be able to help us to understand about septic arthritis. And I'm just gonna read it quickly. It's in the office. You have vital signs, temperature 39.1, so he has a fever. Blood pressure 118/80 mercury. Heart rate 98 per minute. Regular and respiratory rate is 20 per minute. So he does have a fever. Chief complaint: knee pain with swelling and fever. History of present illness. A 42-year-old white male with no significant past medical problems presents to your office with 2-day history of fever, chills, and pain in his left knee associated with swelling. The patient reports that the fever and chills started 2 days ago. Last night, he noticed moderate to severe pain and swelling in his left knee. The patient is unable to ambulate well due to the severity of the pain. There is no history of trauma to the joints. He denies any previous episodes of these symptoms. He also denies IV drug use or insect bites. The patient's mom has a history of rheumatoid arthritis. Review of systems are unremarkable. He has no allergies. Past medical history: no past medical history. No history of hospital admissions. Social history: he's sexually active with his wife and denies having multiple sexual partners. He does not smoke or drink alcohol. So I'm pretty sure at this point, this patient has knee pain, knee swelling, he has a fever, and he has chills, and he also is unable to ambulate because of the pain. And his mom also has rheumatoid arthritis. So I'm pretty sure, thinking about some things that could actually be wrong with this patient. I talked to a lady about septic arthritis during this week, and and she said that most of her patients actually end up getting prosthetic joints, and that's basically true. That's also a risk factor for septic arthritis. I mean, with this patient's symptoms, he could be having degenerative joint disease. He could be having rheumatoid arthritis. He could be having systemic lupus erythematosus. He could be having Lyme disease. He could be having having osteoarthritis. He could be, having joint trauma. Maybe due to an accident. So I mean, those are some of the slipped capital femoral epiphyses, especially if it's someone that is younger, cafe Peter Caffey's disease. That's also another differential. So I mean, those are our differentials. Then also it could be septic arthritis, which is the topic of the day today. So going to septic arthritis. Going to septic arthritis. Which is a very interesting topic. We're gonna learn what it is. We'll learn how common it is. We'll learn the risk factors. We'll learn the causes or the etiology. We'll learn about the clinical presentation, the differentials, and then we'll learn about the clinical presentation. What are the symptoms? What signs do we see on clinical examination, physical examination? We also learn about treatment, I'm sorry. Then after that, we learn about laboratory orders, diagnosis. How do we diagnose that this patient does have septic arthritis? That's in terms of laboratory orders, in terms of imaging, and then also we learn about treatment. That's in terms of medications, in terms of physical therapy and other non-medication protocols. And then we also learn about prevention and then follow up if necessary. So with that, what is septic arthritis? Well, it's actually a direct invasion of the joint space due to by various microorganisms, and it's most commonly caused by a variety of microorganisms. The ones that have been implicated include mycobacteria and fungi. That's from an article written by Brush in 2004. How common is it? Well, 20,000 cases of septic arthritis occur in the United States, and that's 7.8 cases per 10,000 per 100,000 persons per year. So the similar incidents occurring in Europe. So these are pretty interesting numbers. 20,000 cases per I'm sorry, 20,000 cases, and that's 7.8 per 100,000. And these are also similar in Europe too. So, that's actually a pretty interesting number. I mean, it means that it's actually quite prevalent in our community. So what are the causes? There are lots of things that can cause it, and it's actually divided into age. In infants who are less than 3 months, it can be caused by Staphylococcus aureus. It can be caused by Neisseria gonorrhea. It can be caused by group B streptococcus. It can be caused by Enterobacteria, by Enterobacteriaceae. In children who are 3 months to 14 years, it can be caused by Staphylococcus aureus, streptococcus. That's in 14% of cases, and for Staphylococcus it's in 27% of cases, and also Streptococcus pneumonia, Haemophilus influenza in less than 3% of cases, and that's actually due to vaccination that have been increased widely, and also gram-negative bacilli. In adults who have STD risk, it's normally caused by Neisseria gonorrhea, which is actually most common. It's also more common in women by a factor of 3 to 4, and typically causes migratory arthritis. It can also be caused by Staphylococcus aureus, Streptococcus, and gram-negative bacilli. In adults who have no STD risk at all, it's caused by Staphylococcus aureus 50% of the time, Streptococcus species, gram-negative bacilli. In joint aspiration or injection, is caused by Staphylococcus aureus. In joint trauma, it's caused by gram-negative bacilli, anaerobic bacteria, Staphylococcus aureus, and joint prosthesis. In early infection, it's caused by Staphylococcus epidermidis. In late infection, it's caused by gram-positive cocci and anaerobic bacteria. Other causes include umbilical catheter used in the newborn. So if the newborn has umbilical catheter, then that's actually one of the causes of septic arthritis. And then also what are and then also in intravenous drug use is caused by atypical gram-negative bacilli like Pseudomonas. In rheumatoid arthritis, is caused by Staphylococcus aureus, Streptococcus gram-negative, and gram-negative bacilli. That's three bugs in rheumatoid arthritis. That's Staphylococcus aureus, Streptococcus, and gram-negative bacilli. And by that we mean like E. coli. And then in systemic lupus erythematosus or sickle cell anemia, is caused by Salmonella. In hemophilia, it's caused by Staphylococcus aureus, Streptococcus, and gram-negative bacilli. In immunodeficiency, it's caused by Staphylococcus aureus, Mycobacterium species, fungus, gram-negative bacteria, Brucella, Nocardia, and Mycobacterium, and also by fungus. If the patient happens to be a delightful 40-year-old gentleman who actually is a gardener, and he comes in with septic arthritis, then you could be thinking it could be gardening or agricultural causes, and that includes the bug, Sporotrix, skanky. And then also for marine related causes, you're thinking it could be Mycobacterium marinum, especially if they're maybe like a sailor, or if they're in the Navy or something like that. And then so that brings us to the differential diagnosis. We actually talked about that earlier. What else could this actually be, apart from what we just discussed earlier on? It could be reactive transient synovitis. It could be transient synovitis of the hip in children. It could be Calfe-Perthes disease, and we talked about that earlier. It happens in newborns. It could be slipped capital femoral epiphysis, which happens in adolescents due to obesity. It could be psoas abscess. It could be obturator internus pyomyocytes. It could be obturator internus muscle abscess. It could be acetabular osteomyelitis. It could be polygenic sacroiliitis. It could be vertebral or disc space infections. It could be proximal femoral osteomyelitis. It could be sickle cell anemia caused by Salmonella. It could also be juvenile rheumatoid arthritis and neuroblastoma. So what are the risk factors? What actually predisposes a patient to have septic arthritis? Does it happen to everyone? If they have artificial joint implants, if they have a bacterial infection somewhere else in their body, maybe they have sepsis, or maybe from pneumonia or from cellulitis, then that actually puts them at risk of having a septic arthritis. If they have chronic illness or disease, like in diabetes or rheumatoid arthritis and sickle cell disease, then that will put them at risk of having septic arthritis due to the compromise of the immune system. And then also intravenous or injection drug use, that's also a huge factor. Medications that suppress your immune system, if they are steroids, if they are on the immunomodulators, that can actually also increase their risk of having septic arthritis. And also if they have a recent joint injury, if they have recent joint arthroscopy or other surgery. So it's not quite uncommon to see a patient who just had joint surgery who now has to go back to the hospital because they have a fever and they have developed septic arthritis. So now we're down to the clinical presentation. What are the symptoms of septic arthritis? And septic arthritis, they will have a fever, which is actually present in only 24 to 50% of cases. They also have an ill appearance, so they have fatigue, malaise, and then they also have decreased use of the affected extremity, inability to work on the joints. So those are the signs that you see, and also pain around the joints, and also sometimes they have swelling too. And then what are the signs of septic arthritis? They have rapid onset monoarticular joint inflammation, so the joint actually gets inflamed. Then they also have joint pain with motion. So as they're walking, as you ask them to maybe walk, they actually have pain with that. That has a sensitivity of 100%, but poor specificity. Then they also have joint swelling. So they have swelling of the joints. They have joint warmth, due to the interleukins and all the fever substances that are produced around the joints. That's unreliable. They also have joint erythema, so redness around the joint. Basically, they have a significantly decreased joint range of motion. They're unable to move their joints. They also have a significantly decreased weight bearing on infected joints, and also limb paralysis from inflammatory neuritis. So that actually happens sometimes. The patient actually has a compressed nerve, and then they actually end up with that. So those are the signs that we see. So now, how do we diagnose septic arthritis? How do we know that, a patient comes in with septic arthritis? How do we know that that's what the patient actually has? Well, a complete blood count with differential, that's actually very important, because with that you can be able to know if there's any infection. That's very helpful. It actually shows leukocytosis, with a left shift. It shows that there's an infection going on. And then also that actually has a likelihood ratio. It increases the likelihood ratio for septic arthritis. Then you start thinking that this is really septic arthritis. Then also the white blood cell count is normally more than 10,000. That has a likelihood ratio of 1.4. And then the neutrophils more than 90. That has a likelihood ratio of 3.4. Then the comprehensive metabolic panel, these are actually to check for any electrolyte imbalance, and also for any renal or hepatic etiology, which if they have any coexisting infections or coexisting pathology, then that can actually be the problem. So and also the erythrocyte sedimentation rate, because you're thinking it could be septic, so you want to do an ESR. So that's normally typically more than 25 mm mercury in septic arthritis, and then also and most often in children too. Another test that is also used to check for inflammation is the C-reactive protein, and that's normally more than 20 milligram per dl in septic arthritis. And it has a test sensitivity of 95% in children, and also you want to do a synovial fluid analysis, and that includes the synovial fluid culture, the synovial fluid gram stain, the synovial fluid lactate, LDH, the synovial fluid just analysis to see what the color of the synovial fluid is, and then also And yeah, so that's actually basically it. So the synovial fluid WBC in non-prosthetic joints normally shows more than 50,000 white blood cells, or more than 90% of PMN. So that actually tells you that this is actually bacterial in etiology, and it has a likelihood ratio of 4.7 for septic arthritis. In prosthetic joints, you have more than 1,700 white blood cells per mm mercury, or more than 65 PMNs. Then the gram stain might actually help you to know exactly what bug is actually the problem, and then also and that has a test sensitivity of 20 to 60%. And then the bacterial culture has a test sensitivity of 30 to 50%. If it's in a polyarticular joint infection, then it has a likelihood it has a test sensitivity of 75%. And all of these, the gram stain and the bacterial culture helps to guide treatment. It tells you what antibiotics that you are going to need, because there's so many antibiotics out there, and it's very important to be able to tailor the antibiotic regimen to the patient's to the causative of microorganism. Then the synovial lactate normally is less than 10, and that has a very, very high likelihood ratio of septic arthritis. And then in gonococcal arthritis, you normally have clear to opaque synovial fluid. The synovial fluid WBC is 30,000 to 100,000. That's more than 80% PMNs. The gram stain is positive in less than 25% of cases. Culture is positive in less than 50% of cases. That doesn't mean that these tests are not important, even though sometimes it's negative. They are actually very, very, very important. Then for the synovial fluid WBC, you have 10,000 to 20,000. That's the number. That's more than 50% PMNs. And then also for tuberculous arthritis, the synovial fluid is actually opaque. That's a lead for you to start thinking it could be tuberculosis arthritis if the synovial fluid is opaque. And then also the gram stain is positive in less than 20% of cases, and culture is positive in 80% of cases. So that brings us to what imaging are necessary for septic arthritis. Well, first of all, you want to do a radiology, so a joint X-ray. That's imperative. And with that, you can see early changes. You see distension of the joint capsule or joint dislocation. So that's actually on the X-ray. We'll talk about it as we do the clinical case. And in late changes, you see joint space destruction. And epiphyseal cartilage resumption, metaphysis erosion. So that's actually the findings that you see in late changes. And also, you also want to do a joint ultrasound. That actually is done bedside using a high frequency linear probe, 9 to 15 meter hence, and that actually identifies effusion. So if the patient has arthritis, maybe like rheumatoid arthritis, and they have an effusion, that will help to be able to determine that they have an effusion, and also guide that decision to go into the patient's joint with a needle to check for synovial fluid and to extract that fluid. Also, advanced imaging include CT, a computed tomography, or magnetic resonance imaging for unclear diagnosis. So if you're not sure, you want to go ahead and do a computed tomography, and also a magnetic resonance imaging, and also a nuclear scan can be used sometimes. A PET scan can also be used. Now the CT or the MRI does not distinguish infected prosthetic joints. So it's going to tell you that there's joint pathology, maybe the distension of the joint capsule. It's going to probably show some fluid, but it won't really tell you if it's infected or not. The only test that can be able to help you get to that conclusion is by doing an arthrosynthesis, and that's by getting some fluid out and then testing the fluid. So how do we treat so procedures is arthrosynthesis. So that's a very, very interesting procedure. You get needles, numb the area, and then you go in, get some fluid, and then you do a synovial fluid analysis. I've done quite a few of that. Then treatment, what medications are needed to treat septic arthritis? Well, there are lots of medications that are used depending on the microbiology of the causative agent. Empiric antibiotics is two drug regimen. So drug one is vancomycin 40 milligram divided every 6 hours IV. Drug 2 is cefotaxime 50 milligram per kg IV every 8 hours. And then also it's very, very important to modify your antibiotic selection based on blood culture. Then the other two drug regimen is vancomycin 40 milligram divided every 6 to 8 hours IV, and cefotaxime 50 milligram per kg IV every 8 hours. And then if you want to use one drug, then you're thinking maybe like cefotaxime 50 milligram per kg IV every 8 hours. Other two drugs regimen include clindamycin. No, include those that we actually I'm actually talked about. But then in terms of monotherapy, you actually wanna think about clindamycin 7.5 milligram per kg IV every 6 hours, or linezolid 10 milligram per kg IV every 8 hours. And then also you also wanna give ceftriaxone 1 gram IV every 24 hours, or cefotaxime 1 gram IV every 8 hours, or ceftizine 1 gram IV every 8 hours. Vancomycin can be given, that's 15 to 20 milligram per kg IV every 8 to 12 hours. Then cefepime 2 grams every 8 hours IV, or meropenem 1 gram every 8 hours IV. Ceftriaxone 1 gram every 24 hours, or cefepime 2 grams IV every 8 hours is also used. Ciprofloxacin 400 milligram every 8 hours, or levofloxacin 750 milligram every 24 hours. For gram stain with gram-positive cocci, like staphylococcus, or it's vancomycin 15 to 20 milligram per kg IV every 12 hours. Then for gram stain with gram-negative bacilli, that's like E. coli, then it's cefepime 2 grams every 8 hours IV, or meropenem 1 gram every 8 hours IV. For polyarticular arthritis, you are thinking it could be ceftriaxone 1 gram IV every 24 hours. And then other drugs include ciprofloxacin 750 PO twice a day, or ofloxacin 200 milligram PO twice a day, or rifampin 900 milligram PO every day. And then oxacillin 2 grams IV every 4 hours, and rifampin 900 milligram PO every day. Most of the time you actually give parenteral antibiotics. If you want to give oral, that's also okay, depending on how sick the patient is. But this is normally given for 2 to 4 weeks for this patient. Then procedures, we talked about arthrosynthesis. Is actually performed as an office procedure or at the bedside of the patient, and you just get the needle, numb the area, and then you get the fluid and you check for lots of things. A synovial fluid analysis normally consists of the synovial fluid gram stain, the synovial fluid culture, the synovial fluid lactate, the synovial fluid LDH, the synovial fluid protein, white blood cells, and then so that's basically, and also for crystals too, and that will actually guide your diagnosis, whether it's bacterial, whether it's viral, whether it's immunologic or inflammatory in etiology. And then, so how do you prevent it? Well, prevention, there's really no way to prevent it. Normally, if you're predisposed to it, that's actually gonna cause you to have it. So in terms of important points, after completing antimicrobial therapy, patients with SRO septic arthritis regain 46 to 50% of their baseline joint function. So if a patient has septic arthritis, that's why it's very important to be able to start treatment with antimicrobial therapy, because that will actually help them to regain 46 to 60% of no, to 50% of their joint function eventually. So that's actually pretty good. That's from an article written by Horowitz et al. 2011. And then also have a little important information about the clinical features that you see in viral septic arthritis compared to parvovirus B19 septic arthritis. Actually, yeah, I'm sorry. It's the information of, the important points that I have are the differences between the various viral septic arthritis. So for parvovirus B19, that actually occurs in adult women with erythema infectiosum, and they often have an itchy rash. So the patient comes to you with an itchy rash and arthritis, then I think it could be parvovirus B19. For a patient with muscle aches and rash, that's normally hepatitis A, and that's in 10% of cases. For hepatitis B, it actually starts in the pre-icteric phase and normally resolves as the jaundice develops. And most times patients actually develop chronic arthritis in patients with hepatitis B. In hepatitis C, they have a history similar to hepatitis B. In rubella, that's both natural infection and vaccine related. The onset is possible before, during, or after the appearance of the rash. Usually resolves in a few weeks, may reoccur, and more commonly may persist. So it varies. It may actually occur after the rash, and it may actually resolve in a few weeks, or it may actually still be there. Then for HIV, it develops over several days, and several knee or ankle pain is characteristic, and it responds excellently to NSAIDs. Then if they have a sudden onset of severe pain in the shoulders and the elbows, that resembles an acute gouty attack, then that's something that you have to also think about, and you might have to use opiates to control the pain. Mumps is also a causative factor that occurs in adult men 2 weeks after the presentation of parotitis. So now we're down to coding and billing. How do we bill for this? How does the physician, how does physician remuneration occur after a patient has septic arthritis? Well, ICD-9 is 711.0, ICD-10 is M01, M03. So that's how you bill for that. That's how you code for that. In terms of billing, that's on the amount of time spent on the patient. So that's probably maybe like 9913, 9914. Most new patients get billed as a 9915 or 9914. So then prevention. We talked about no prevention, but prophylactic antibiotics for patients who are at risk can actually help, and that's mostly for patients who have like sickle cell, who that's just one of the things that they actually experience in one of the prodromes. So that's when it actually comes in useful, because antibiotics have a lot of risk factors for resistance. So that's why we're a bit hesitant about doing that. So this patient does have septic arthritis, and we are at the Powerball question. We are 2:58 into the show, and the question is, after completing antimicrobial therapy, patients with SROs, septic arthritis, regain 46 to 50% of their baseline joint function. True or false? Well, the answer is actually true. It's actually true. But it's something I want you to check out. To send me the answers. We have talked about lots of interesting topics this week, and I want you to go and answer the Powerball questions. The answers are there, but I want you to send them to me so I can be able to do the drawing. And if you post on my Facebook wall, if you like a video, one of these videos, you can be able to get a shot at winning the Powerball questions. These are questions that are designed to be able to help us to read the articles. So I want to encourage us to be able to go ahead and answer those questions. References. I want to thank Bruce J, who wrote an article on septic arthritis, and I want to invite you all to check it out. Horowitz et al. Approach to septic arthritis from the American Academy of Family Physician. I want to invite you all to check it out. And then also Septic Joint from the Family Practice Notebook, a very, very good article. American College of Physicians, Approach to Joint Pain, very, very interesting article, and very interesting. It has lots of very, very interesting tools that you can be able to make use of to understand this topic, septic arthritis. So with that, that actually brings us to the end of today's show. It's 3 o'clock. We have talked about the overview of the physical examination. I don't see anyone who has posted on my wall or who has logged in. But I'll just go ahead and talk about one of the questions from the American Board of Family Medicine. It's a question on arthritis, which I thought was actually pretty interesting. And since we are talking about septic arthritis today, that's actually why I wanted us to be able to talk about that. But then right before we do that, we'll go into the residency interview question of the day. We've talked about lots of lots of residency interview questions, and it's a very interesting time in our career right now, with all the interviewing going on. And we have been able to been able to get to meet new people, to be able to get to learn about the programs and how we can be able to plan for the next step of our career, which is residency. So I'm pretty sure that you're having fun on your interview trail, and I invite you to share your stories. So I invite you to post on my wall, send me an email. I'll also share them too. It's very, very important that we keep each other enlightened about the best way to go about getting a residency program that will help us to achieve our career goals for the next 3 years. So today's question is, do you have a criminal record? And it's a very, very important question that most programs and potential employers will ask employees to determine if there are any previous criminal records that will affect the potential employees' job performance, licensing, and future practice. And licensing is actually very important for physicians. So that's why potential employers and graduate medical education programs will ask that question. And for criminal records, this includes any criminal record at all. It includes arrest records. It includes driving and vehicle records. It also includes incarceration. That's like arrest records and sex offender records. These records are actually visible to anyone by background check or even a Google search, and they can be expunged after 1 year, but they are still gonna be there. And so these employers want to know a little bit more about what happened, and what you did, and what effect it has on your career. But it will not affect your licensing in most states, and that's actually from personal recent research. I actually called up some licensing agencies, and I asked them, and they told me that it's on a case-by-case basis, and it will not affect licensing. So that's actually very that's pretty good, because that will help to produce more physicians. So an answer to these questions, like I said, criminal records are available on background checks, and a very important part of the recruiting process for graduate medical education. And I'm currently involved in various community programs against domestic violence, elder abuse, and sexual violence with the state of Texas. After a domestic violence case, after a personal domestic violence case, due to my personal philosophy against domestic violence, which I think that community education can be able to eradicate completely. I'm also aware, that criminal records will not affect licensing or in most states, like I just stated earlier, from personal research. And I think that this rule will actually help to produce more physicians who are dedicated to improving the the health of the community. So that's the question of the day. Do you have a criminal record? That's a very important question that you could be asked as you go on your on your residency interview trail. So I want you to look at the answer and also to share your interview experiences in this section, which we called the perspectives of the residency interviewing experience. So so and then with that, I'm gonna also talk about the Twitter chat that we had yesterday with the National Residency Matching Program, and they had a lot of useful information. And that's after I talk about the residency program of the day, and that's St. John's Medical Hospital or Providence Medical Hospital. That's in Michigan. And I was opportunity to interview there. They have a very strong program. They have 160 residents in 19 residency programs. They have they're major affiliates of Wayne State University School of Medicine and limited affiliation with University of Michigan Medical School, and also with University of Health Sciences College of Osteopathic Medicine and Pontiac Osteopathic Medicine, and some other institutions too. They are accredited by Joint Commission of Accreditation for Healthcare Organization, the American College of Physicians and American College of Surgeons, the American Council of Teaching Hospitals, Association for Hospital Medical Education, Michigan Association for Medical Education, OHEP Center for Medical Education. They also their curriculum is actually pretty interesting. For first years, they have hematology and oncology for 1 month. They have general internal medicine for 6 months. Then they have coronary care unit for 2 months. They have emergency medicine for 1 month. They have electives for 1 month. They have vocational conference for 1 month. In second year, they have general internal medicine for 6 months. They have coronary care unit for 2 months. They have intensive care unit for 1 month. They have electives for 1 month. They have hematology, oncology for 1 month, and vocational conference for 1 month. In third year, they have general internal medicine for 4 months, coronary care unit or ICU for 1 month. They have electives for 6 months. They have vocational conference for 1 month. They have 5 teams on the general medicine rotations, which consist of an attending, a senior resident, 2 junior residents, and 1 or more medical students. And each team will be on call every 5th night and will follow patients admitted that night to the internal medicine services. And the patients will be placed throughout the hospital without any geographical limitation. They have 7 faculty members, and they have more information about the ICU, the medicine floors on their website. They also accept applications through ERAS. The contact information is actually the program director, which is Elizabeth Lewerens. That's the program coordinator, and she can be reached at her phone number 313-343-3875, or her website or her email, which is elizabeth.lewerens@stjohns.org. So that's her contact information. The program director is Mark Paschel, and he has he actually has a lot of good things to say about the program. The strength of the program is that they are a community-based program with a strong academic flavor. So didactics is actually pretty important to them, and they have the resources of the award-winning St. John's Hospital. All the faculty, they have clinical appointments at both Wayne State and St. George's University. They also emphasize on family-oriented maternity care procedures and practice management. They pride themselves on producing residents who have the flexibility to pursue individual career interests and be able to emerge as well-rounded residents, equipped with knowledge and skills about patient-centered medical home and electronic medical records. And then also they also have a sports medicine fellowship that you can be able to apply apply to. I actually applied there. I'm sorry. I actually interviewed there, and my interview experience was actually pretty good. You know, yeah, they have a strong program. I was very impressed by the structure of the curriculum. By the emphasis placed on didactics, by the facilities, by the patient population, and the dedication of the faculty and the residents too. So, I would encourage anybody to apply there and to aim towards, getting the residency education at St. John's Hospital, Providence Hospital, St. John's Family Medicine Residency, Providence Hospital in Michigan. And the questions that I were asked at the interview was, tell me about yourself. We've talked about that on the show earlier. That's pretty easy to answer. I'm a 2007 graduate of American International School of Medicine with 10 years of clinical experience working as a certified nurse aide at various hospitals, long-term care facilities, nursing homes, with patients in their private homes, from 2 graduate medical education programs with a master's in business administration from Davenport University, Grand Rapids, Michigan, and research experience from UT Southwestern Psychiatry Department, and currently involved in preventive care and education, utilizing my Ustra and YouTube channels, and applying for residency this year in primary care. My strengths include my interest in research, creativity, and education. My plans for the future include getting into a graduate medical education program that is equipped with with everything needed, the facilities, the faculty, the residents needed to be able to produce competent residents. My hobbies include Zumba dancing, charity walks. So that's basically a good way to answer that question, but a good way to answer that question. And then also I was also asked about what do you want from a residency program. That's a very, very important question that I think we've actually talked about on this show. So and a sample answer would probably be I'm looking for a residency program or graduate medical education program that is equipped with dedicated faculty, with facilities, and also to train residents to become competent physicians, and with a diverse patient population, and to be able to equip me with the skills needed to be able to emerge as a competent primary care physician. So that's a sample way to answer that question. With that, we've talked about the overview of the history of physical. We've talked about septic arthritis with the powerball question, and then also that's that majority of patients who are treated with antibiotics actually come out with come out recovering their joint function, recover most of their joint function. So. And then we've talked about the residence interview question of the day, which is do you have a criminal record? And also we've talked about our featured residency program today, which is St. John's Family Medicine Residency Program, Michigan. And with that, I want to round up the show. I want to talk about some of the things that we do at Dr. Chiquito Mentoring Ustre preventive care practice. Which includes being part of TAWAS, an association of the American Academy of Family Physicians. I actually picked up 3 schools that I've contacted to see if I can be able to get their middle schoolers to get involved, make some posters that have been effective in helping adults to quit in the past. And prizes will be given at the national conference in July. And I want you all to get encouraged. I am actually giving out prizes because I'm part of I have free books, so if you actually volunteer, then you actually get a free book, and I collect the labels for education, so that actually gives me gives free books that can be able to motivate our middle schoolers to be able to take a shot at winning. It would be nice to have someone from the Dallas metropolitan area. And then also, I also offer free preventive health care to the community of Dallas, to community churches. I've contacted Potter's House, and hopefully, we might be able to, provide free health care. And also, participate in charity works. And if you sign up, you get your own web page. You can actually be able to talk about the work. Let people know about it. It's always good to be passionate about the cause, and get people to learn about it. So with that, I want to thank you all. And the schedule for next week is going to be posted over the weekend. But we'll have some Zumba dancing tomorrow by 12 o'clock, and I can be able to, teach you some Zumba. We'll be dancing to Move Like Jagger. I've done that routine before, but I'm going to do it again on my show, and we can be able to have fun with our families, lose some weight, and also be able to learn that Zumba routine again. And with that, I want to thank everybody who has logged in, and wish you a happy rest of the day.